This conference will now be recorded.
Good evening and welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, August the 24th, 2026. A special welcome to our first time visitors as well as hello to our regular participants. I am Boykin Jordan, your moderator for this evening. I will be assisted by Bill Franklin, Stuart Jordan, as I like to say, no relationship, um, as well as AnCan's founder Rick Davis will be here, and there's a couple other regulars that chat in as well. AnCan would like to note that this group is a peer-to-peer support group and should not be construed as medical advice. Anything that we tell you should not be construed as medical advice. We are here to share our collective experience and answer your questions. We hope to provide you valuable information that we encourage you to discuss with your doctors and medical team. Before we begin, AnCan would like to thank our sponsors for all our prostate cancer virtual support groups. They are Novartis, Blue Earth Diagnostics, Foundation Medicine, and Telex, as well as thanking our participant base. If you would like to support AnCan, please visit our website at www.ancan.org or www.ancan.org. At AnCan, we have multiple prostate cancer support groups for our attendees. We have a group that focuses on active surveillance for those who are considering or who have opted to postpone or avoid an active treatment. Tonight's group, which addresses those with low and intermediate risk that are planning for or have had active treatment. We do not address recurrence in this group and instead invite those people to join our high-risk recurrent group, advanced group prostate cancer group. Other prostate cancer groups are under 60 for advanced prostate cancer, gay and bi men, and the European prostate cancer group. We also have special groups for men speaking freely and veterans. So with that, we will start off with Jim, since he was here first. And Jim, I'll just get started and just go through the series of questions. Are you ready, sir?
Yes, I am. I think so.
Okay, great. So your name is Jim Carr, and I can see the spelling here on the screen.
Yep.
Okay. How old are you, Jim?
75.
75. Okay. Where do you live?
A little tiny town called Lolita, California.
Okay. Okay. Can you tell us a little bit about your diagnosis? What was your PSA at diagnosis?
Okay, it started out at 11.37 on the first one. Second one was 12.07, and then they started the rest.
Okay. Have you had an MRI yet?
Yes, I had it on April 15th.
Okay. What about a biopsy?
Yep, had that June 9th.
Okay. How many cores or samples were taken?
16 cores and 12 were positive.
Okay. What was your Gleason score?
I had two 4+3s. I had two 3+4s. I had a couple of 3+3s. So they said, I guess it's a Gleason score is 7.
Right. Okay. For your Gleason scores that were in, I'm trying to figure out what is your percentage of force that you had. They tell you that on your biopsy?
Percentage of the core.
Or
On
what
one of them,
percentage?
it was 80%.
80%?
That was on one of them, yes.
Okay. Was your MRI a fusion biopsy?
I don't know about that.
Okay.
The MRI that was done
No, I'm
for.
sorry. I should have asked it this way. Did you have an MRI fusion biopsy?
I don't know. I had the MRI, like I said, April, and then in June I went to the San Francisco VA to have the biopsy done.
How was your
Uh,
biopsy done?
Well, I laid on the table and he poked so many holes in my butt, my parts whistle. But
Okay.
he just went in there and just kept taking samples, and dictating where they were coming from.
Okay. So your biopsy was transperitoneal or is it transrectal?
No, it was
Not,
transrectal. If he
That's
did
what
it
I'm
that
thinking.
way, that's what he's telling us, Boykin.
Okay.
He's not sure, and from what he just told us lying on the table, I think we can
That's
gather that it was transrectal.
okay. Okay. Thank you. Did you get a second opinion on your biopsy slides?
well, I got a second opinion actually today from UCSF about the whole thing. He said he did see the biopsy because they kept asking me for it, and then when I saw him, he said yes, he did get a copy of it.
Okay. Okay. Okay, we'll come back to that. Okay. Have you had a PET scan?
Yes, I have.
Okay. What
That
type
was
of?
done. That was done on July 21st. I had the PET scan done for that. It said that it has not spread.
Okay. Okay. Was it any kind of special type of scan they did?
Well, they said it was a PET scan. They gave me the radioactive stuff, so I glowed in the
So
dark.
PSMA?
Yes, PSMA. Yes.
Okay. Okay. So when transition, that was good enough. We're going to transition a little bit. And just find out a little bit about your medical team. Do you have a radiation oncologist?
Yeah, I saw them just the other day. It was at St. Joe's Providence in Eureka, California. Um, where his name was Dr. Join Y. Luh, Luh.
Okay. Okay. What about a medical oncologist?
I don't have a specific one. I've been going through the VA and talking to mostly residents, I guess, and they kind of change out. So I haven't spoken to the actual surgeon if I go that route, which I'm kind of leaning towards.
Oh, okay. Okay. So you may have been, did you think I asked you about the urology oncologist?
And no, don't know anything about that part.
A urologist yet? Okay. Okay. So far you've talked to a radiation oncologist,
Yes,
is what I'm hearing. Okay.
right, right.
Okay. So how did you hear about AnCan?
I heard about it through, I ended up joining the Mayo Clinic's prostate cancer group. And there's a guy on there, his name is Jeff, right? Yeah, that had mentioned it. So I thought, oh, I want to follow up on anything and everything.
Okay.
So
So referral from Mayo. Okay. All right. Do we have your actual contact information so that we can put you on future newsletters and things like that?
sure, what would you like then?
Uh, you can, you probably don't know how to put it in the chat. Let me see, I'm looking for Bill's email address. If you,
I'm here. I'll put my email address in the chat
chat.
window, and
Okay.
you can email me. I just need your email address, and we can sign you up for reminders and such.
Okay, I am not very good with these computer thingies. I don't even know what a chat
Yeah,
thing is.
so up in the upper right-hand corner, there's a little silhouette with the number 19 next to it, and then there's two little speech bubbles. If you hover
Yeah,
your mouse
okay.
over there, it'll say chat, and you just click on that, you'll see the chat string that's going on.
Oh, okay, so I go into that and I can get your email address.
Yep,
And
just
then
put it at the bottom.
put
It's
it in
very
there.
simple. Just my name's Bill Franklin, so it's bfranklin@ancan.org.
B Franklin
Yep.
at
So all
AnCan.
AnCan.org. And any other new guys, if you wanna get the reminders or some of our newsletters, you feel free to email me your email addresses if you haven't already signed up for our groups.
I think I have, but then again, I don't know.
that's
Okay.
okay.
I've
That's
been
good
on the
that you have.
website and I've been through some of the stuff there. We'll find out.
Does any of the other moderators have any questions that I didn't ask or should have asked?
Jim, just since you're a veteran, we have a group that specifically focuses on VA process. And
Yes.
I don't know, guys, Bill, when's the next meeting?
I was at the last one.
Oh, okay.
Okay.
Well, that's
I'm
why I didn't make
familiar
sure.
That's why
with
you
that.
look familiar, because yeah.
Yeah.
Okay.
Yeah, that's, I remember seeing you there, and I tried to email Captain Jim, but it kept getting bounced back, so I gotta ask him what I did wrong.
Okay.
He wanted a copy of my biopsy report and stuff, so I fumble with things, big fat thumbs, and I gotta get a
So,
10-year-old kid off the street.
That's all.
Yeah,
okay, Jim, you can
Yes.
reach Jim Marshall at veterans@ancan.org. Veterans@ancan.org will go to Jim Marshall.
Yep.
just veterans without anything else.
Without anything else, veterans@ancan.org.
Okay.
Okay. Any other, Bill? Any? If not, Jim, I don't hear any other questions popping up. So what questions do you have for us?
Well, that's been, I've been researching all of this for quite some time now. And I'm finally getting some of my answers. I had a very good meeting today with a doctor at UCSF for a second opinion. And I got lots of good information from him, which I wasn't getting prior to that. But I am alone here now. And when I was looking at radiation, and they wanted me to go on that Luprin, which I understand can basically lead to depression with a lot of side effects there, which I was really trying to avoid. And so I've been looking at surgery, and I wasn't too sure about how the VA in San Francisco did. So I've been hoping to find people that may have had surgery there to see how they did. But then the guy at UCSF was telling me that, yeah, they've got 4 surgeons there that are in with UCSF, and they're excellent, I guess, and have very good results. So that was kind of reassuring, because the guy that I talked to, I was kind of unsure of, but he turned out to be a resident and not the actual surgeon that would be doing the job. So it was quite a relief. But in terms of the cancer that I have, he was suggesting also surgery because it's considered aggressive but not advanced. And I've got large cribriform and perineural invasion. And I've forgotten already, and I already turned I got pages of notes here with all of this stuff. But also because of my trouble with peeing, which is pretty bad. It was almost as bad as before I had a TURP done quite a few years ago. But he was explaining that radiation may actually make it worse because of the bladder not liking the radiation. And that also leans me towards surgery, because apparently with the surgery, he said that you'll be incontinent for sure for 2 months, but then at the end of 2 months, they have a 50% rate of recovery from that. And then at the end of 6 months, it was, I forgot where that page, oh, there it is, 70 to 80% after 6 months and 90% after a year. Whereas the radiation, that was supposed to be 6 weeks, 5 days a week of
Slow you down
radiation.
there, Jim, a little bit.
What's that?
We actually have a hand up. So,
Oh,
Mark,
I didn't,
go ahead, Mark.
go
That's
ahead.
okay. You're going to see it. I see it. It's okay.
Okay, well, I'll share some of my biases on this. But first off, in larger studies, they're showing that it may approach up to 50% still incontinent at the end of a year. With the post-op screening before only 5 days of radiation, you're going to see somewhere between 1 and 3% may have incontinence. And the issue of the Lupron, you want to look at something like the Arteria AI, and that may tell you what the benefit is and the percentage reduction in recurrences if you take the ADT, and then you can make that decision. But there's a recent study out of England, and there are a lot of problems with the study. It's called the PROTECT study. And what they did in that study was they took people with disease confined to the prostate and did surgery, active surveillance, or radiation. And long term, there was no difference in the outcome. But at 2 years, they reanalyzed the material looking at those people who had large cribriform pattern. And what they found is that those who elected to do surgery had 3 times the recurrence rate of those who chose to do the radiation. Again, a lot of problems with how they recruited patients. They didn't have the MRIs before biopsies. They didn't have the better radiation machines that we do today. So it's not a clear study, but it suggests that it may not be a slam dunk, that you're not going to get a better outcome or better chance of cure or control. Is best when you have a 4 to talk about control rather than cure. So I'd think twice. With 80% of the core coming back as 4, or 80% of the cancer as a 4, and 12 of 16 positive cores, there's a good possibility that you may have residual disease and come to need radiation and ADT afterwards anyway. One more thing, and then I'll quit here. PET scan. You said the PET scan showed that you don't have spread outside the gland, and that's not true. What it shows is that they couldn't find disease or they didn't see any. That's an important distinction, because regardless of what's going on, up to 30% over the next 10 years may have it come back. And if the prostate is gone, how does it come back? Well, it's disease outside.
Because it got out to begin with. Yeah, I saw that in studies where it has to be a certain amount in order for it to be detected through the PSMA PET scan. So if it's a minimal amount that has escaped already, well, and then it's already escaped. 2 big concerns about my decision. Number one, under the radiation part, that the drugs, the lupin, in my particular situation right now, I'm really afraid of going deeper into depression because of the aches and the pains, the fatigue, the lack of a drive of just wanting to do anything and ending up on the couch watching TV. Yeah, I lost my wife 2 years ago. I also now recently have my back thrown out again and tore rotator cuff muscles. So I got a lot going on, and it includes a lot of pain, both mentally and physically. And if that stuff is to increase my physical pain with the aches and pains in the muscles and the joints and all of that, and I have to take it for 6 months, they said that it takes an equal amount of time for it to get out of your system back to normal. So that's like a year's time. And at the end of that year, I'm concerned about the quality of my life. And also, I was talking to the guy today, and he was saying because of my issues of peeing already, where I'm up 4 times a day, I don't get good flow. I don't empty out. I have all these, that the radiation part can exasperate that and make it even a little bit worse.
Right.
So the surgery, I'm figuring that's in and out, and then I got to deal with incontinence, and that's not as big a deal to me as depression. I already have enough days where sometimes I don't feel like getting out of bed. And
So Jim, I can tell that you've got a lot to think
Right.
about, and
I,
if you want to give me your email address right now, I'll write it down. Rather
Okay.
than waiting for you to email me.
Okay, sure. It's my name, Jim Carr. So it's
All right.
JimCarr 100RS@gmail.com.
Let me make
It's
sure I
my
got that
name,
right. It's Jim Carr with another R and 100
correct?
and followed by RS
That is correct. It's my name
at
and my
gmail.com.
motorcycle. I have
All
a
right.
R100 RS. So
All right, so I've got it, and I know we have a couple other groups that might be of interest to you because you have talked about the depression and some other things.
Right.
So we have a group called Veterans Speaking Freely, which meets tomorrow night by coincidentally, as they say, and it's I'm in there, Boykin's in there. We have a few guys in there. It's just veterans talking to other veterans about you know about life, not necessarily focusing on your disease, but more on getting through life when you've got a chronic disease or a critical illness, right? So
right.
we'd love to see you there tomorrow night if you'd like to show
That's
up, and
Tuesday
I'll
night.
send you.
Tuesday night is open for me right now.
Yeah, that's tomorrow night at
So
8 o'clock.
yeah, Eastern time.
Yep.
5 o'clock my time. I have to keep
Oh,
that
okay.
in mind.
I didn't catch where you were at. I'm sorry about
Yeah,
that.
yeah, about as
Hey,
far west as you can get without paddling over to Hawaii.
Yeah.
Way
so,
up north at like Cape Mendocino, where it bumps out there at the very
You did
north
say
end.
you're a small town in California, right?
Pardon? Yeah. We have more cows than people here.
So that group's actually it's exact same format. It's just a different room. It's a go-to room just like this, and the link is on our calendar. But if you have questions about DN, you can email me.
Okay.
so
So
Jim,
we have
just a couple of thoughts. Oh, sorry, Rick. Just a couple of thoughts. I think I'm sorry, Rick. I mean, Bill. Just a couple
oh
of
good.
thoughts. Like Bill was saying, follow up with him, but I also want to point out that at 75, I think that is pushing the window on thinking about surgery. It's not.
I've heard that.
Yeah, I think you're pushing the window there. The other thing is that I think you need to, and it's in the already posted in the chat, the Memorial Sloan nomograms, Kettering nomograms, and what that addresses is the percentage opportunities of recurrence that your actual, if you did a surgery, would be successful. It's just it's a little dated in the time when they did it, but it's still relevant and trying to sit back down and look at the information. So I think along with what Mark told you about surgery, I think you should take a look at those nomogram studies as well. And then finally, I think that we need to know who you talked to, like at UCSF. Who did you actually see?
His
Because
name, it was on my thing. I don't know that I wrote his name down on my pad because it's in the notes. I know I did have it written down on here. Somewhere, cyber and high bill system. I think, yeah, UCSF, yeah, UCSF, Dr. Rishi Sikar. Does that sound right?
I don't know him.
You did say he was a resident, right?
No, he was a surgeon.
Oh, he was a surgeon. Okay.
Yeah, he was one of their big guys. And he knew all of the guys at the VA, which were back way.
Yeah,
Dr. Washington.
Yeah, I mean, we know Sam Washington real well.
Okay.
You know, I'd be very surprised if Dr. Washington was recommending surgery at age 75. This is a tough surgery. This is not like even, and Bill's had both surgeries, replacing his shoulder, Bill Franklin, and a prostatectomy. I mean, you know, they can replace a shoulder in an hour and a half. This is a 3 to 4 hour surgery if everything goes smoothly, and Dr. Mark knows this well. It's not an easy surgery to undertake, and for me, I mean, they've sort of changed a little bit, but I always felt that over 70 they shouldn't do it. Maybe 71, 72 if you're in fantastic shape, but I get very nervous, and I have we have a great relationship with UCSF, and I think there's a lot of good surgeons, urological oncologists there who would not encourage surgery unless there was some very, very special circumstances. That's gotten 2 people to put their hand up. So I'll hand it back to AnCan.
okay.
To Boykin, sorry.
Yeah, so no worries. Okay, guys, we're going to be about 2 minutes each on these, and then we're moving on. Okay, Albert, I saw your hand first.
Yeah, I don't know. Maybe we should let David go first. I wanted to address the ADT, but if you're on the surgery topic and David has something to say about that, I'll come back to the ADT. It's just a
Albert,
short.
you're on the clock now, as they say in the NFL draft.
Okay, what I was going to say is there's an alternative to Lupron, and that's Orgovix. It's an oral pill that
I get it. The VA won't give it to me unless I pass all of these different things, and it gets down to I have to try Lupron first, and if I'm intolerable of that, then they will give it to me. But otherwise, I can't get it.
Okay, I'm sorry.
And I can't afford it if I just paid it out of pocket. You know, it's really, really expensive.
Are you on Medicare?
Oh, VA. I have Medicare A and B, but I don't have like D prescriptions or things like that.
Let's move on to David.
David, go ahead. Sorry.
Just real quickly, Boykin mentioned the Sloan Kettering nomogram. Jim, I also had a 4+3. I ran the Sloan Kettering nomogram on myself, and I'll give you a preview of what you're likely to see because you got a 4+3 as well. More than likely, if you do surgery, the chance of avoiding a recurrence for 5 years is 47%, and the chance of avoiding a recurrence over 10 years is 30%.
Thank you, David.
Okay. Just to address the surgery a little bit, I was just under 2 years ago, my back surgery was 5.5 hours, and it was pretty intense. And I came through that pretty good. In fact, I was able to walk again after that.
But how, Jim, How long ago did you say that was?
It would be 2 years this coming November. So I was 73.
All I can say is you're 2 years older. That's all I can say. So, you know, I mean, it's tough, man. And you've got your head, you're upside down. You've got your head below your feet for 6 hours. There's a lot of surgery has its place, but I would be really, really concerned.
Okay.
So
I'll take it all into mind. I'm trying to get everything.
Come back. Take the information that you got tonight, and then come back. And it sounds like there's going to be some dialogue between you and Bill. So we'll leave it at that. And Joe, are you there? I see you. Hey, okay, Joe.
Yes.
Cool. So we see. Oh, you're in Hawaii. It looks like. What's your last? Tell us your name, Joe. First and last name.
Joseph Kuharic, Kuharic. I'm on Kauai in Hawaii. My partner's here on another screen. That's Uli. He's in Santa Cruz. So
Okay.
otherwise he'd be sitting next to me if he wasn't in.
What's your age? I'm sorry. Yeah. Okay.
2.
I'm sorry.
62.
62. Okay. Copy. Okay. And you already told us where you live in Hawaii. We got that. Okay. Kauai. Okay. What was your PSA diagnosis?
It started at 4, and it climbed to about a 7, and then it leveled off for a while, and then all of a sudden it spiked up to a 10 and an 11. That I got my first test back in June 2024 at the age of 60.
Okay. So you gave us the 2-year trend. Okay. Have you had an MRI yet?
Did have an MRI.
Okay. When was that?
I'm gonna guess. I didn't prepare with all the dates. I have dates of my biopsy and
Rough is good.
I'm gonna say November of 24. So the year yeah.
Okay. Moving on to some biopsy questions. Have you had a biopsy yet?
I did have a biopsy in September of 25.
Okay. How many cores were taken?
There were 19 cores taken. 8 of them were positive.
Okay. What was your Gleason score?
3 plus 4.
3 plus 4?
Yes. 3 plus 4.
Okay.
Were all 8 cores 3 plus 4, or there was a smattering of different readings?
There were a couple that were.
Are there any 4 plus 3s, in other words?
Between 10 and 15% for Gleason 4.
Okay. Go ahead and say that again, Yuli, if that sounded like you.
Joe, correct me if I'm wrong. I believe it was between 10 to 15% for Gleason 4.
Correct.
Okay.
When they give you that reading, it could be in referencing one particular core or the total amount of 4 from all the samples. So that would have to be, you'd have to read that specifically from the biopsy. But our question was, it was all 3 plus 4s. Did you have any 4 plus 3s or 3 plus 3s or?
I had a couple 3 plus 3s.
Okay. And how many of the 3 plus 4s were there total?
I don't see that on here necessarily.
Okay, that's all right.
Okay, that's okay. We'll dig into that a little later as we go along. Okay.
So the reason we're asking is because if if they took a particular core and they said 15% was type 4, 15% was the 4 from that core, you'd have to take into account how big was that core. What kind of percentage are we talking about? So you want to dig a little deeper into the actual biopsy and analyze the percentages and all of that. It helps you.
Yeah, so one thing that I see here was just, I only see the summary. It says percent of overall tissue involved by carcinoma was 10%.
Okay.
Okay. Okay. So we should think for now back off, Rick. I'm sorry, Bill, leave that piece alone and think it's
Yeah, go ahead.
this
Go ahead.
right. It was 4. Yeah. Okay. So did you have a MRI fusion biopsy?
Yes, I did.
Okay. When did you have that?
Your last MRI was in September of 2024, right? Or November of 2024.
I'm sorry. I'm ill prepared for this.
No,
I
it's
would
all
have
right.
to-
No, we're trying to help you out. So an MRI fusion biopsy would be you had a recent MRI that showed something, and they used that MRI to guide the biopsy into your prostate to specifically hit that area. So
Correct. They did. Yes.
okay, but you told us your last MRI was in November of 2024. They used that MRI for the biopsy, or did you have a more recent MRI?
That's what they used, I believe.
The November 2024.
I had a second MRI in the spring of this year.
Okay, there you go. They used that one.
Yeah. Yes.
That one showed lesions of concern that they wanted to use for your to target for your biopsy.
Yes.
Okay. It's not that you're ill prepared, and I'm not trying to badger you. We want to get to the bottom of exactly what you went through and how it informs what you've got as far as prostate cancer. So.
Right. No, I understand.
Okay. So was your biopsy, was it transperineal?
Yes.
Okay. And did you get a second opinion on your biopsy slides?
I did. I got a second opinion from two radiation oncologists, so Dr. Siegel on the island of Kauai and Dr. John Lederer at the Cancer Center of Hawaii on Oahu.
Okay. Okay. And so can you tell us which medical system you're in? Certainly. I'm gonna ask some questions about that. You brought it up. Are you like in what are you using for medical system out there in Hawaii?
I'm not sure what you're getting at. What are you asking?
So I'm trying to figure out, is it like the University of Hawaii or Kaiser?
So there's some Queens, there's some Straub, there's some Kaiser all involved. There are not very many doctors in Hawaii, and so they all kind of intermingle.
Okay.
So I'm like the king of having to get a referral to do anything.
Okay, I understand. So, yeah.
Are you a Kaiser patient, Joe? Are you a Kaiser patient?
No.
No. Okay. Because the reason we're asking is because we're pretty familiar with the Hawaii system at all levels. And if you're a Kaiser patient, it makes life much, much more difficult to get the treatment you need. So you're not using Kaiser. Great.
I am not.
I had a when you told me, when you said you had transperineal biopsy, I had a feeling you weren't a Kaiser patient because it's very difficult to get a transperineal if you're a Kaiser patient.
Right.
Okay. So I think, so I have you down with seeing some radiation oncologists, medical.
Yes.
Have you seen a medical oncologist yet?
I have not.
Okay.
No.
Nope. It's not a right or wrong.
He doesn't need one, Boykin. He doesn't need a medical oncologist as a 3+4.
Right. That's true. Urologist? Okay. So have you seen a urologist?
Yes.
Okay.
I've seen 2 urologists. I saw a urologist shortly after my first PSA tests, and he did an examination and said because of the shape of my prostate, he wanted to refer me to a better urologist on Oahu.
Okay.
And so I flew over, to the other island and Dr. Chow.
Okay. Yep. So I'm going to come back to the PET scans. Have you had a PET scan yet?
Yes.
Okay. What type did you have, and when did you have it?
I don't know what type. I'm sorry. I had it in spring of this year, probably May of this year.
Okay.
Do you have the results from that, or?
Somewhere. I'm sorry. I apologize.
It's no
Yes.
need to apologize. You're in the exploratory phase of getting help from us, so we got to ask these questions, right?
No,
Yep.
I appreciate it.
I know you already signed up for our groups, and you signed up for the gay and bi men's group. So you'll be able to also get information there.
Yeah.
If you go to that group. And the other thing I was going to say is we do have some resources, and they're not AnCan specific resources, but we have resources in Hawaii. I know a lot of the men that I know from Hawaii have gone to the West Coast of the United States for treatment for prostate cancer. And that kind of talks toward what you said about treatment in Hawaii, right? So.
Right.
That's understandable.
Yeah, but in doing the research, that I myself and my partner Uli did, we found a lot of good stuff from the Cancer Center of Hawaii, and eventually I was able to get a referral there and met with the radiation oncologist there, Dr. Moderators, and between him and Dr. Janet Siegel on Kauai, who originally had given me information and had, put me in on the active surveillance route. Once the numbers started to jump and get all over the place, I actually, on August 12th, almost 2 weeks ago, had radiation seeds implanted. So I'm already a little bit downfield.
Okay. So I'm going to let Stuart has his hand up, so I want to let him ask a question.
Now I was going to ask about surveillance, but it sounds like we're already past there.
Okay. Okay.
And that was that I had conversations with my, PCP, my urologist, both of the radiation oncologists, and I even went back to the original urologist who gave me the original referral, and all of them, in me towards the seeds.
Okay. So what questions do you have for
the urologist that wanted to? He was like gung ho to cut me at every step of the way.
Oh, that's what they do. They're surgeons. So.
Yeah, that's right.
Want to operate. Yeah. When you say you had seeds, so you had brachytherapy, or?
I did.
Okay. And how long ago was that?
12 days ago. 12 days ago.
12 days ago?
How you doing with those seeds?
I'm doing okay. I think I'm doing okay.
Yeah.
The one thing I'm not so sure about is there's symptoms that I'm having that don't seem to be on any of the things that people tell you to expect.
Tell us the symptoms.
I'm burning up. I feel like I'm having hot flashes. I'm sweating all the time. It's
okay.
Unbelievable.
Are you burning when you're peeing?
No.
Okay. Well,
I'm not.
So in full disclosure, I had seeds, but I also had a lot of other things because I was more advanced. So I had radiation, and I was on hormone therapy, and I didn't get my seeds until the very end after I'd finished my IMRT radiation, but I did get seeds. And for me, they were easy, probably because anything that was going on was already going on by the time I got the seeds. I've known several guys to get seeds. I think it's a very good procedure. Mostly the issues that they have are urinary issues. I have not heard about people having hot flashes. I will say that I cannot see a connection to the seeds because we're not doing anything at all with your testosterone or with your hormone system. Dr. Mark, can you think of any? Let me just check with Dr. Mark. Dr. Mark, can you think of anything that would cause hot flashes through brachy?
My thoughts would be the possibility of infection. That infection might result in hot flashes and might trick you in doing it.
Oh, your trick in doing what were you going to suggest, Dr. Mark?
Oh, I'm not going to suggest anything. I'm except maybe in most cases there are better methods, maybe for the very high risk patient to do the seeds. But I just I don't see an advantage now that we have much better precision.
But it's done, Mark. It's done. It's done.
No,
it's done.
I have nothing to advise.
Okay. So I'm just trying to get to how we can best help Joe and Uli. Mark's suggestion is a really good one. It could possibly be an infection. Have you talked to the uro-oncologist about the hot flashes?
No, I mean it only started 2 days ago, and I've been trying to see if that's something that is normal.
Let him know, because it could be an infection from they've got to use needles to put those seeds into place. So yes. It's a real possibility. Any other strange? No. Okay. Well, I mean, I kind of like seeds. I mean, they've gone out of fashion for a number of reasons, largely because the urologists don't train with them anymore. They just don't do it. So you got to find people to do it. You can do high dose brachy as well, which is similar. I think the brachy gets the results. It's not inferior. And it's easy, and a lot of times it's pretty successful. So I would say you're doing great. I would say you're doing great. But I would also definitely recommend reaching out to your uro-oncologist and saying you've started getting these hot flashes, and I really like what Dr. Mark said. It could be from an infection, because it's possible.
Yeah, thank you.
Yeah, I definitely I run into the same thing with my family. They've got a cold or they're under some sort of course of treatment and they're having another symptom, but they're like, oh, should I mention it to my doctor? And I'm like, yes, mention everything to your doctor, But
Rick, the only thing, I'm sorry.
No, go ahead, Mark.
The only thing I wanted to say was the brachy is an excellent method in the hands of a physician who is experienced. It's not the kind of thing where you want to show up for the person's first case. Now, that's not, for you since you've already done it. But the main thing about it is it's a great method. It involves anesthesia. So you are still getting put to sleep. You may need a catheter. But the main thing is get to someone who's not an amateur or a weekend course, and then goes out and says, yeah, I'll offer this to my patients.
So at this point, Joe, I got to ask you you got questions for us other than what we've already discussed, because a lot of the guys come to this group, they're still exploring what to do for treatment, right? But you've started a treatment path.
Yep.
So it's wait and see what the treatment does for you.
Right.
Is there anything else we can help you with at this point?
I don't think so, but I'm going to call my oncologist the second I get off of this, because I want to get something to handle the infection that I may have.
Oh yeah, you're in Hawaii, so it's like 3 o'clock in the afternoon, right?
Yeah.
I used to go over there to work. I miss it. So
I bet.
Joe, don't assume we're right, please. Okay.
Oh, yeah.
Don't assume we're right. We can't give you
One
medical. Well, maybe Dr. Mark can give you medical advice, but we can't give you medical advice. That said, it's a possibility. So don't sort of jump in and say, I want something for the infection. We don't know. It could be. So just ask the urological oncologist and lead them along. And, they may say, okay, we'll put you on Cipro. Maybe we'll put you on a course of Cipro for 5 days or something like that, and see if that helps you. If you're willing to take Cipro, or another antibiotic, but Cipro is a very popular one for urinary infections.
Well, we definitely wish you the best of luck, and
let us
come
know.
back to the meetings. Let us know what's going on.
Alan Edel leads the gay bi group. He's really experienced, especially in areas of radiation. So we're not allowed to join. We've been Bill and I have been X'd out of that group. Okay, which is fine. So you can come back and tell us if you weren't happy, but we can't go. But it's only once a month, and I think the next one, it's on a Sunday. I think it's going to be on the 13th of September, if I remember.
That's correct. Yep.
Yeah.
Okay. And come back to this one, and we'll help you with whatever's going on.
I intend to. And
okay.
I thank you for your time. And I do apologize for not being prepared, but
don't worry about it, Joe. You're fine.
That's quite all right. We'll drag those answers out of you somehow.
Yep.
Joe, the only reason why I had my answers is because I watched a video of this group before I came in, and I saw the questions that they asked the new guys that were in that group. So I wrote everything down, figuring they were going to ask me the same question.
Came prepared.
Good Boy Scout.
I was lucky.
Yep.
Okay. Lucky. Came across a video.
So, gents, let's slide over and get started with TJ. Are you still there with us?
I'm still here. Can you hear me?
Yes, I can hear you. Okay. So TJ Parker is your first and last name. What you want to go by? Can you tell us how old you are?
47. I'll be 48 in next month.
Okay. Where do you live?
I live in Houston, Texas.
What was your PSA at diagnosis?
I was diagnosed in December 2021, PSA of 6.1. Since then, I've been on active surveillance. I also was joining the active surveillance group for a while, but I quit going after a while. And I had my most recent PSA in January of 2026 is 10.4.
Okay. So in January 2026, you said it was 10.4?
Yes.
Okay. Have you had a MRI?
Yeah, so since I'm on active surveillance, what my doctor recommended was that I have yearly MRIs and biopsies. So
okay, what was your last one?
My last biopsy MRI was in December, I think, of 2025. And I have, I think, 12 cores. One was a 3+4 and 4 were 3+3.
How many of those were positive?
5. So it was 5 out of 12.
5 out of 12. Okay. Okay. You told us your Gleason score. Do you know what percentage the 4 was?
I'm not sure. I'm looking at some now. It says, but I don't really know what it means. It says 10% of tissue, only 10% pattern, but I don't know.
Okay. Was this did you have an MRI fusion biopsy? Is that what?
Yes, fusion biopsy, transrectal.
Okay. Okay, and have you gotten a second opinion?
So initially, I got diagnosed in 2021. I started with Kelsey Seabold. 2023, I got a second opinion with MD Anderson because my original doctor recommended surgery. I wanted to get other options, so I went to MD Anderson in 2023. And more recently, going back to my last biopsy that I had in December 2024, they said that one of the cores had changed from a 3+4 to a 4+3, but then MD Anderson came back and said, no, it hasn't changed. It was still the same, the 3+4.
Okay.
And this was in December.
In December.
I also had the Polaris test. I don't know if they recommended to, and it said it recommended I do active surveillance. That was in 2023.
So, you said your last biopsy was in 2024?
No, December 2025.
Yeah.
Oh, December 2025. Okay.
Right. Yeah.
And you did get a second opinion on that one?
Yes.
Right.
All right.
Okay.
Would you be willing to get a third opinion?
Well, I'm open to. I'm open.
I mean, the fact that you had one opinion that changed it, and then another one that said it, changed it back. We'd like to direct you to some of the preeminent prostate pathologists in the country, which we have linked on our website. We have a section on our website for second opinions, and Dr. Jonathan Epstein and Dr. I'm going to get it wrong because I always think of my doctor, Dr. Zhao. I forget his first name. I'm sorry. But these guys are, Dr. Zhao was Dr. Epstein's student before he, branched out into the big wide world of his own. And they're two of the best prostate pathologists in the country. And there's other references on there of other people that we've seen very good results for second opinions on. So we'll post the second opinion link in the chat window.
Yep.
I just not to slow roll you or anything, but if you've got 3+4, and of the 5 of the 12 cores that were positive, how many were 3+4? I'm sorry, I think I missed it.
2, 3 with 3+3, and 2 with 3+4.
Okay, and you did say something about a 10% of the core or something.
Yeah,
which would be a low amount.
Yeah.
But again, it goes back to the other question: what's it referencing for percentage? Either total or a particular core. So that calls for a more careful read on your biopsy. But if you go to the website and check out Dr. Epstein, I think that he'll give you a true and honest reading.
Okay, what do I need to send him?
What's that?
What do I need to send him? The actual the disc?
Your doctor will send him the slides from your biopsy.
Okay.
Either you can get there's a link to his website on our website, and you can get the information on how to send it, or you can ask Dr. Epstein to talk to your doctor and have him ask for them. So there's two different ways to do it. So
Stuart's put the link in the chat for you. Just put it in at 9:07.
Okay, I see it. Thank you.
Okay.
And when you said your PSA was 10.4, have you been seeing any kind of trend on your PSA rising?
Well, yeah. So in December 2021, it started at 6.1. Then they gave me some medicine to see if make sure it wasn't infection. It went down to like 5.9 or something like that.
Right.
And then since then, it has slowly increased.
Okay. So from 2021 to now, it's gone up roughly 4 points.
Yes, sir.
Okay. So that's not a rapid rise. It is a rise, which you should be concerned at your age with a 10.6 PSA. What they did find was a fairly, intermediate disease, right? So you've got time to research what you need to do. And my first advice is the second opinion from Dr. Epstein. And then, so do you have questions for Stuart? I'm sorry, Boykin, did you get through your whole questionnaire?
I'm
Did you get through your whole questionnaire? I'm sorry.
Well, no, I'm done now because I think we have everything.
Because I asked a lot of questions.
I didn't have the PET scan thing. You asked about this PET scan. I didn't have one of those.
Right. Yeah. I wasn't gonna ask
so
you. Because I wasn't gonna ask you. I got educated, so we're good.
Yeah, okay, we always say, have you had any additional tests, scans, blood tests, anything, that related to prostate cancer that we haven't talked about yet? So.
No, I haven't had. But my question is primarily about different types of treatment. So I went, like I said, started 2021. My initial doctor recommended surgery. I joined the active surveillance group. They were like, "No, don't worry about surgery right now." And so I began trying to look at other means of treatment. So I talked to a radiologist about the brachytherapy. I met someone about the photon therapy. I talked to somebody about HIFU. But all of the people I speak with say that because of my age and the likelihood of it coming back, and that I couldn't do any type of radiation or any other type of treatment, because if it came back later on, they wouldn't be able to do the surgery because they said
we've talked about that a lot in this group and in other AnCan groups. When I was diagnosed 12 years ago, I was 51, just a few years older than you, so I was on the younger side also, and I heard the exact same thing, But Dr. Mark's got a comment on it.
Yep.
Go ahead, Mark.
So thank you. So I hope I don't burn up the airwaves here with that. I'm going to tell you my opinion, and you can follow it or take it for whatever it's worth. And that is that someone who tells you if you have radiation first, you can't have surgery, is telling you that you ought to turn around and walk away as quickly as you can. There are a lot of reasons why that's just plain bullshit. The first is that if you do radiation first, you can do radiation again if it happens to be on the edge or outside. And with the newer, more precise machines, you can even retreat the same area. You have other alternatives. You have medications, you have chemotherapy, you have lutetium-177 and other radiation treatments that are focused. You wouldn't want to do surgery initially because as young as you are, that could mean 30 to 40 years of incontinence and erectile dysfunction, which really isn't fun. It involves anesthesia. And as a surgeon, unfortunately, I got a knock on wood. I was lucky, never lost anybody. but people die in surgery, and it's usually not the ones that you suspect. It's often the ones where they're healthy and everything is doing well, and you're thinking this is going to be an easy case, and it turns out it's not, and disaster follows. There's one guy in one of the prostate cancer communities who had Gleason 3+3. He was a marathoner, and his urologist convinced him that, just get it out, and then you won't have to deal with it again. He did the surgery, and 12 days later had a pulmonary embolus and died. That's not going to happen. I mean, there are problems that can happen with radiation, but the newer treatments are better. But someone who tells you that you can't do surgery later is blowing smoke. And that's not a person who's kept up. And if they haven't kept up in the other areas of prostate cancer, I don't know that they'd be that good a surgeon either. So it's about time to look elsewhere.
Okay.
I'll add to what Dr. Mark said. Guys come in here to this group and tell us that they had they didn't have an MRI fusion biopsy, never had an MRI, just had a blind biopsy. Mm-hmm. We say the same thing, that doctor's not keeping up with the current standard of practice. So they know one way to do it, and they kind of keep doing it that way forever and ever. On the flip side of what Mark said, I was 51. I had a prostatectomy. I was in very good shape physically, and I think that was a very large contributing factor to my recovery. So I unfortunately already had local metastasis, so it was outside of my prostate cancer. I mean, outside of my prostate. So I had to get further treatment. But again, I went through that too. And I ran the gamut of treatments. 12 years later, I'm still here. So with your disease, and again, I'm not a doctor, I'm a glorified security guard, so don't take medical advice from me, all right? But with your diagnosis right now, pursue that second opinion, see what Dr. Epstein thinks, then look at treatment options and carefully weigh what you can consider acceptable side effects or whatever, the scientific knowledge says could possibly happen to you. And then from there you go, right? But I'm betting you'll be here 12 years later just like I am.
Or longer.
Hope to be.
Yeah, probably younger, probably longer than me now.
Okay. Yeah, because that was my main other thing was just when you're trying to decide which option, what's your process for trying to figure it out? What's the best course of action?
Again, I'm not a doctor, but in the overall scheme of things, like with the Memorial Sloan Kettering nomograms, you look at those kind of things.
What was that again? I'm not familiar with that.
The Memorial Sloan Kettering, the nomograms, like we talked about earlier with Jim. Okay. It's a very large database of treatment that other men have had, and it asks you questions, and you had similar paths to them. You you answer the questions, and it gives you a percentage of likelihood of either recurrence or something down the road. So, and that's in the, someone else just posted that again in the
okay, yep, I just clicked on it. Okay,
in the chat window. But don't rush. I don't think you have to rush right now.
Oh, okay, because the doctor
weigh your options carefully. Get that third opinion. And
yeah, because all the doctors keep rushing me. So and because what you were saying too about the doctors are not keeping up. So I'm going to MD Anderson. That's why I changed doctors, because I thought they were supposed to be the best. And I've been to 3 different doctors at MD Anderson, and they all recommended surgery because of my age.
I'm going to tell you, they're going to recommend surgery because you're 48 years old and you got a PSA of 10, right? And they found some cancer, so they say, hey, just take it out. But like Mark said, there's quality of life issues down the road, so there's considerations. I mean, David in Portland.
David has his hand up. Yep.
TJ, did you say you have not had a PSMA yet?
You said, say again?
Did you say you have not had a PSMA PET scan yet?
Yes, sir. No, I have not had a PET scan.
I'd want to get one, especially if I were going to get surgery, because if you have surgery and there's a little cancer outside the prostate, then you're going to end up in the situation Bill just described that he was in.
Okay.
Yeah, PSMA PET scans were, if they existed when I was treated, they were experimental. So.
Okay. I'll make that my next target. Okay.
All right, Boykin, I'll turn it back over to you.
Okay, so TJ, I was just going to say one thing. I think you have time, and I think that besides just the medical treatment, if I'm only 64 and I went through all of this at 61, but I have also had a kidney transplant much earlier in my life, around your age, so I understand the bigger questions that I think you have to deal with as far as work-life balance, health, what is all that other stuff going to mean? And so I think there's some other things you have to kind of step back outside of just the treatment of just the disease, but think about the type of life that you want to have, and what are your career aspirations and other things, because you have a lot of experience because you've been managing this so far in active surveillance for at least 5 years, from what if I'm tracking correctly. But I think at your age, you still have another 30 to 40 years left reasonably. It's not unreasonable for you to think that. So I think you have to think through the decisions you make today, how will they impact you over those, and how will they impact the loved ones around you. So I think you have the time. I think you just need to kind of think about what does TJ, need and want as far as a life. And don't forget that element of it, because everybody else that you're going to come across is just going to be largely focused on medical outcomes, but you need to think about life outcomes for you. Yeah, I see David has his hand up.
One other thing, TJ, given your age, I think if I were diagnosed in my 40s, I'd want to get a germline genetic test just to see if there's any sort of a genetic mutation that could be involved with it. Cancers with genetic mutations tend to show up earlier. I know I got a genetic test and was surprised to discover I had a mutation. So quite, a little obsessed on that subject.
Okay, good.
Understandable, and but I'll throw you a flip side on that one too. My maternal grandfather had prostate cancer, and my father had prostate cancer. I have prostate cancer, and I have a brother with prostate cancer, and we have no genetic markers. So, but of the 4 I just mentioned, 3 of us served in the military.
So hey, TJ, is there a history before we move off? Is there a history of prostate cancer in your family?
Yeah, my dad had prostate cancer. He got diagnosed, and it's probably about 10 years ago in the 60s. I was saying about 65.
Okay.
Somewhere around that. I was in the military too, but I was in the but I'm the only one that got diagnosed, I guess, at this age. I have a brother too, younger brother, but he doesn't have anything.
Okay.
Any breast or ovarian cancer?
My grandmother had breast cancer. She passed away from it, but it was years ago, 30 years ago.
The same mutation can be involved with prostate and breast and ovarian and a few other kinds.
Okay.
The last piece. Go ahead, Rick. I'm sorry.
Before you go on, TJ, where did you serve? I mean, did you serve in any of the areas where there were toxic materials, burn pits, and?
Not that, but I was in the Coast Guard, and I used to work with chemicals, and I used to inspect oil tankers, gas tankers, chemical tankers.
Okay.
Chemicals.
Okay. And are you aware of, because you mentioned you went to the AS group, are you aware of a veterans benefits group so that you can make sure you're getting what you're entitled to?
I got my disability, but I didn't realize I was going to the VA, but I didn't like the doctors, kind of what he was talking about earlier, with they changed our doctors too much and stuff like that. So
Right.
that's why I ended up switching over to because I still work.
Are you on TRICARE?
No, I retired, but I retired. I did active duty in our reserves, so I can't get TRICARE until
Okay.
I reach.
So here's the thing with the disability that I'm and particularly under, is it called, correct me, Colonel Boykin and Bill, the PACT Act. That's
Right,
the
that's what I was
correct name,
thinking.
right? So, you know, under that PACT Act, you may be able to get more. I mean, even if you're 100%, you can get 120%, 130%. So I really recommend that you go talk with some of the guys in that veterans navigation group.
Right.
The other thing is that it's good to be dual enrolled, because there may be times when you can get treatment and drugs a lot cheaper through the VA, even if they're not your principal, your main provider, your principal provider.
I still go to. I mean, I go a few times a year, but yeah, I'm still involved. I just haven't.
Okay.
So have you active VA?
Yeah, I am active VA.
Yeah. So definitely stop by Dr. Jim's group, Captain Jim's group, and just review with him what you're getting, and if the guys in that group think you can get any more.
Okay, I will do.
Are you? Is TJ signed up, Bill?
Not for the veteran. I'm signed up for, I guess, now this one and for the active surveillance.
Okay, well, we'll add you to the veterans.
You are signed up for the veterans group.
I am. Okay. Well, I don't.
Well, you get the email.
Yeah.
I ain't got it. But I'll check.
Check his reminders, because he writes very good reminders with all kinds of great information in there. Mr.
TJ,
Parker.
what's your first name?
It's Thedrick. THE.
Yeah, that's what I thought. You're on here. You're signed up for our veterans groups, and we're sending you the emails. I see that you opened this email, so
okay.
I'll double check it. I'll double check everything. So
okay.
Okay, but there may be some more disability you can get as a result of the PACT Act, or even if not as a result of the PACT Act, because of your duties that you did in the Coast Guard, where those things have already been caused to advanced cancer, prostate cancer in particular. So that's why we're saying you need to go see join Captain Jim's group and get some insight from him, because we've had people come in and not thinking they were going to get anything, and they ended up qualifying for benefits that they didn't realize they were entitled to.
Okay, I'll check it out. Thank you.
Okay, so with that, we're going to move on. And Chris, I had you next. Are you? Chris, don't see no Chris. Looks like Chris is gone. So Dan, are you still here? Yes, Dan is still here. Oh, wait a minute. I see Chris. Never mind. Hold on. Chris, are you there?
Oh, here. Can you hear me?
Okay. Yeah.
I had my microphone on mute. Sorry.
No worries. That's good. Okay. So Chris Helm is your first and last name. How old are you?
It's Christopher Helm, and I'm 73.
Okay. Where do you live?
I live in Seattle, Washington.
Okay. So what was your PSA diagnosis?
About, let's see. Just for background, between 2011 and 2023, it was between 2 and 5, and then it jumped dramatically in 24. I had diagnosis between 24 and 25, and it's basically been between 8 and 10 for the past 2 years. Last PSA was 9.
Okay.
I don't know if anybody else, you probably know this, but it appears that if you have any kind of sexual activity before you get your PSA test, it tends to jump it up a bit.
Yeah, certain activity can cause it. Physical exercise, sexual activity, those things can cause your PSA to change.
Yeah.
But it's all good though. But let me ask, have you had an MRI before we go off in the?
Yes, I had an MRI in December of 24.
Okay. You have a biopsy yet?
I had a biopsy in March of 25, and it was a fusion guided, MRI guided biopsy.
Okay.
And the biopsy was a transrectal.
Okay, fusion. What, I missed the date on that again. What was the date?
March 2025.
Okay, got it. Okay. How many cores were taken?
15.
15. Okay. How many were positive?
6.
6. Okay. What was your Gleason score?
3 were 3+4, grade 2. 2 were 3+3, grade 1. And 1 was quite small, and when I printed it out, I lost the part of the report, so I don't see that, but
Okay.
I think it was less than.
Okay, but it wasn't a 4 point. It was not a 4.3 or something like
No,
that.
I did not have any 4.3, and also I think they did not report any cribiform,
Okay.
or if they did, it was minimal.
Okay. All right. And so out in Seattle, who's your radiation oncologist? Who are you seeing?
Radiation oncologist is Christopher Canning.
Okay. What about your urologist?
Urologist is Zachary Panafili. And they're both at Kaiser Permanente, Washington.
Okay. Okay. And how did you learn about us?
Through my brother, who 3 years ago went through all this and got a great deal of assistance and guidance from you guys. And he ended up, his biopsy showed a slightly more serious, but it was still within 3+4, I think. And but he ended up getting radiation. And initially, the doctor that he was seeing was advising surgery. You guys told him to get a second opinion. He got another radiologist. In fact, it may, I don't know if, I don't have his name, but there was a radiologist, pathologist, radiology pathologist, what is radiological pathologist, who had just moved from, I think, from Australia somewhere to University of Washington. And this guy read the reports and told him that, oh, I know what it was. They told him initially that it was outside the capsule, and
Okay.
The second opinion told him that it was not outside the capsule.
Okay. So, okay.
And mine, by the way, also the MRI showed that there was, well, they didn't find anything outside the capsule.
The capsule. Gotcha.
Yeah.
Okay. Okay. And then, are you on our? Do you get our emails?
Oh yeah, yeah. I've been ever since my brother introduced me to you guys. I've been contributing to every month.
Okay.
But this is my first time actually talking with you guys. I did listen to a couple of the sessions last week.
Okay. So thanks for following us. Before I jump to your questions, I want to see if Stuart or any of the other
Uh,
moderators, Rick, have
yeah,
any questions? Yes.
Chris, hi.
Hi.
Since your biopsy was in March of 25, and we're now 18 months past that, what's been going on in the interim? Have you been on surveillance?
I'm on active surveillance.
Okay.
I was in Japan for 8 months, so we sort of held things off, and we're basically checking my PSAs periodically. I'm probably due for another biopsy, maybe in the spring. Although I also was seeing a doctor in Japan who said that if they didn't give me another MRI this fall, he'd be happy to schedule me for an MRI there. It's pretty amazing, but unlike the United States and Japan, you can see a specialist within 3 days or 4 days. And the cost is like so much less than here. Everything is like a tenth or 100th of the cost.
So your
I'm
doctor.
I'm sorry that Bill has had to leave. He had a minor family issue. He had to go pick up his daughter whose car broke down. But his wife is Japanese, and they spend a lot of time in Japan. In fact, his daughter just came back from 10 days vacation with her. She went over with her grandma. And I'm sorry he's not here to hear that.
Yeah.
But next time you and he can talk about healthcare in Japan.
Sure.
Chris, your supervising doctor for your AS, has he indicated that he thinks time for you to be off of AS?
Not necessarily. He's always said, if it would give you peace of mind, you can do the radiation. But so far there's nothing urgent, and we can keep doing the AS. And but he did suggest that perhaps by next spring or early 2027, it wouldn't be a bad idea to get another biopsy.
Okay.
Well, another MRI and possibly another biopsy, is standard procedure for surveillance, especially since you've got some 3-4, which puts you on the higher end of surveillance.
Right.
And it's a good thing to sort of know about what your options are. But by the same token, given the choice between staying on surveillance, unless you have a real, psychological concern about it, keep in mind that there's a positive part to being on surveillance as opposed to being treated, because the second whatever treatment you end up with, there are side effects, there are long-term issues that you might deal with. So unless somebody's encouraging you to get off of surveillance, think about it before you run for treatment.
Yeah, and one thing that I've been thinking of, apparently I have about a 96 cc prostate, or at least that's the size. It's larger. Back when I had the MRI, I've had in the past some urination issues, but I've been on tadalafil, and it seems to help my flow. And I don't know if I'm on some herbal things that I don't know seem to work. But so I don't have, if I suddenly am like having difficulty peeing, probably that might lead me to want to take action sooner than later.
Okay.
Well, be careful not to conflate the two.
Right.
Because, treating prostate cancer does not necessarily do anything and could possibly make worse urinary issues.
Yeah.
Yep.
So what are you, so where are you, where's your head at? What are your questions?
The kind of questions you've been asking, actually. One of the questions that, but the doctor did say that because of the size of the prostate, probably the brachytherapy would not be a good idea. And he also mentioned, because my brother had suggested, there's a kind of a gel that's used to
Spacer.
protect. Yeah, it's a spacer. He said, well, maybe because of the size, again, that might not be terribly helpful or useful. So I don't know. Do these things sound reasonable?
Yeah, but now you're getting into you're getting into the real technical aspects as opposed to, you know, the big picture questions there are, if I have to have treatment,
Yeah.
given your situation, what are the docs telling you? So the
Yeah.
size issue and the impact of that on your choices, that's an important area to pursue.
Right.
I wouldn't get hung up on SpaceOAR and that stuff, because
Right. Okay.
that, you know, that's the details.
What about is it too early to ask for a second opinion, and should I wait for another biopsy and see if it's suggesting, if it's more serious, go for another opinion. If it's not more serious, then just wait again.
So it's never too early to ask for a second opinion if it'll make your mind go at ease.
Mhm.
Or and so I think that's an individual call. Me, myself, given the fact that you've been, actively surveilling this for a while and you have another test coming up, I would get a second opinion on the most current test possible.
Yeah. Sounds reasonable.
Mm-hmm. So I see David go ahead, David.
When did you say your next biopsy is scheduled for?
We don't have a fixed date yet, but the doc was suggesting next spring.
6 to 7 months.
Okay. And how often are you getting your PSA checked?
Every 3 months or so.
Okay, good. On the previous biopsy you had, did they do a Decipher test?
I don't know I don't even know what that is.
That's a test where they can use the biopsy information to judge the aggressiveness of your cancer.
Oh, let's see. There's a note on the top that says, and I have no idea if this is relevant. It says, overall score, PI RADS V 2.1 score equals 3. But that just sounds more like the, I don't know what that is. Technique multiplanar. Oh wait, Clariscan. No, I don't see any mention of that. Yeah.
Well, for your next biopsy, that might be a good idea to do, just to assess what's going on there in terms of its level of aggression. And I guess my one concern, the real risk with active surveillance, and I've had this happen to a friend of mine, is he also was a 3+4 and was just watching it, monitoring it, and within a year of his biopsy, he had got another biopsy and it had jumped to a 4+4. So, that's what we want to guard against. And so,
right.
just
Did he have any? Was his PSA jumping up, or was it just pretty much level?
Gradually, it wasn't a big red flag.
Yeah.
Now, in your case, just to get to your size of your prostate a second, I guess the reason I'm bringing all this up is on the one hand, your PSA is about a 10 right now, or a 9.
It's 9, yeah.
And that could partially be, that's getting up there. but it could partially be explained by the fact that you have a large prostate.
Yeah.
But it does, once you're around that area in terms of PSA, it's not a real low PSA anymore.
Mm-hmm.
So I'm just a little concerned about that.
Yeah.
But yeah, I would definitely stick with at least the 3 months, every 3 months. I wouldn't do it any less frequently than that.
Yeah.
And since it's been a couple of years almost a couple of years since you've had your, no, I'm sorry, only a year and a half since your last biopsy. Never mind. I just, definitely stay on it.
Yeah. Yeah. So 18 months is not an unreasonable time to
No, no.
Yeah, especially in this case.
So
I heard somebody say that. I'm sorry, I don't know your names yet, but the fellow with the British accent about is it Rick? Yeah, about
Rick.
That it's very difficult to get Kaiser to do a transperineal.
I think that was in reference to things out in Hawaii.
Oh, I see. Right.
Yes. So he was talking to somebody, Joe from Hawaii.
So is it so it's definitely worth asking my doc if they're doing transperineal now?
Yes.
Yeah, because obviously the first one was transrectal. And,
right. So you should be doing that. Yes, that's considered best practice. So, Chris, I think best advice we can give you is you're doing the right stuff. You see something coming on the horizon. You looked at your family history, and so you're starting to piece together. And so, what I would encourage you to do is start your general education campaign by sitting in more sessions with us here in low and intermediate, or going to active surveillance, because they will have a slightly different spin, and sitting in to get educated so that you can kind of pace yourself and start to formulate your strategy well before you have to make a decision.
Thank you. I plan to do so.
Okay. So with that, we shall get to Dan. Hey, Dan, are you still here?
Hello. Hi. Hello.
Hi, Dan. Yes. Okay. Hey, Dan, what's your first and last name, please?
It's Dan Diessner.
Can you spell the last name?
Sure. Diessner.
Okay, got it. Thank you. How old are you, Dan?
I'm 71.
Okay. And where do you live?
I live in a suburb of Portland, Oregon.
Okay. What was your PSA diagnosis?
At diagnosis, it was 5.11. The most recent PSA I've had, April 7th to 2026, is at 2.69.
You said 2.69?
Yes, that's the most recent one, April 7th, 2026, 2.69. Free PSA was 0.73, and percent free PSA in that was 27.14%.
Okay. Did you get an MRI done?
I did. I have had 3 MRI prostate endorectal coil MRIs.
Okay. Let's focus on the last one.
Okay. And the last one was on April 18th, 2026.
Okay. And what type of MRI was that?
It was an endorectal coil, with the balloon in the rectum.
Okay. Endorectal coil. Okay. All right. Did you have a biopsy?
I did, and I've had 2 of them.
Okay.
And the latest, the collection was 7/15/20 26.
Okay. How many cores were taken on that one?
14.
Okay. How many were positive?
And of that 14, there were 2 that were atypical, couldn't exclude carcinoma. 3 in group 2, Gleason score 3+4. And 1 in group 3, 4+3. Which is what sort of got me off of 2 years of active surveillance.
Okay, gotcha. So 5 cores total is what I'm hearing out of the 14. And then the other one, the big one that brought you was the 4+3.
Right. I mean, there's only Gleason scores on 4 of them, and 2 are atypical, and they couldn't exclude carcinoma, but they didn't do anything further than that. And the 4+3, the tumor involved 25% of the tissue in 3 of the 4 cores.
Okay. So the percentage 4 is on the 4+3 is 25%.
Mm-hmm.
Okay.
The percent Gleason pattern is for 70%. If that makes sense. I don't quite understand that, no.
Right. Okay, right. So was this a MRI fusion biopsy?
Yes, it was rectal fusion biopsy.
Okay, but it was rectal. Okay. Okay. Did you get a second opinion on your biopsy slides?
My slides are in with Dr. Jonathan Epstein.
Okay, so right now as we speak, in progress.
Yeah, I'm fighting a little insurance situation, so I haven't had them process it yet. So I'm trying to get my insurance to cover it.
Yes. Okay. Did you have a PET scan done?
Did not.
Okay. All right.
And listening to people, I'm kind of surprised that they didn't recommend it.
Right. Well, it all depends on your doctor. So it's just asking. Medical team. Who are you seeing? A radiation oncologist and a urologist?
I have. Let's see. Bear with me. I'll grab my notes here. I have seen that my urologist performed the biopsy. His name is Daniel Furlong, Furlong. Everybody is associated with Oregon Health Science University.
Okay.
My radiation oncologist that I met with is Casey Williamson. The surgeon that I met with is Marshall C. Strother, Strother. And I also met with somebody I've seen before as a medical oncologist to kind of just get a third opinion. Oncologist, the radiation guy wants to do radiation, surgeon guy wants to do surgery. I wanted to see what Dr. Yee with OHSU Night Cancer Institute had to say. He used to manage my Eliquis and help me with some other issues. This is my second cancer. The first one in way back in 2010 was started my tonsils, squamous cell carcinoma.
All right. So Dr. Yee, I don't think is a GU, is not a prostate cancer medical oncologist, Dan.
Correct. He is not.
And
Nope.
so there's no point in talking to him because he can't help you make a decision between one or the other. He's not the right guy. What I would say at this point, and I've just communicated this to the moderators, we're going to have to ask you to come back in 2 weeks to finish this off, because we've spent way too long with the newbies. This is Rick, and I'm really sorry to the returning people who needed time. We should have gotten to you much earlier. I'm so sorry. We should have restricted the number of newbies, and I'll take care of this. I'll be sure to take care of this. This is not right. Dan, we're coming up to, Bill and I are going to be in Portland. We're going to be at the Prostate Cancer Conference. So please be sure to let us have your email. I don't think we have it as yet. You can put it in the chat window, and then we'll get a message out to you. And if you come in, next time, and I hope you will, which will be on the 14th, we'll give you priority and we'll finish you off. I don't know if Stuart or Bill are going to be leading that, but we'll give you priority and we'll finish off this session. If there's anything urgent in between, send a message to bfranklin at AnCan.org if you need to get us before. Guys, please, would you move on to the returning people?
Sure. Dan, just so you know, you've got friends in Portland here. David is in Portland and Amir is in Portland. So you guys should reach out separately, either through the chat and exchange emails. There are folks right there that have similar experience with 4+3 that can help you.
Amir lives right down the block from me. We're neighbors and friends, and in fact, he and his wife recommended AnCan to me.
Great. Well, just be sure to put your address in there, because Amir's going to be getting an email very soon, and David is, because we got to get ourselves set up, because we're going to have a meeting with all of our AnCanners whilst we're up there, a social meeting. It's not going to be technical. Don't get me asking about your treatment. This is a social meeting that we're going to have, and we don't know where, but it's probably going to be on the evening of Friday the 16th, but we're sending an email out now in the next 3 or 4 days. So
very well.
Thanks.
Okay. So as far as the old time guys, Ignacio, you were first. Let's see if you're still here.
He's gone.
Ignacio's left, which is really why we've got to be more diligent, guys.
Okay, so Albert, I see you, Albert. Go ahead.
Yeah, I don't really have much. I'm going to start with Dr. Kishin with my mapping and planning on next Monday. And I'd hope to get in the adaptive arm of the anti-court trial that I am going to stay in, but I did not get the adaptive arm, so I'll do regular MR LINAC with him. And at this point, I'm still sticking with Vortex, which is the vascular sparing. So that's it. I just wanted to let people know.
Yep. Thanks, Albert.
You bet.
Okay. Henry. Henry
Yes.
V. Yes.
Yeah, just quickly. So I feel like I'm getting to the point where I need to make a decision on treatment. I'm still on the fence on which way to go. I'm not sure how to make that decision. It just seems like I keep going around in circles. Boykins, your newsletter article was kind of timely for me.
Thank you.
I'm doing it for others, not just for myself. Yeah, I met with Dr. Dorf last week, and she helped me a little bit. But I was surprised because she recommended surgery, which was kind of like out of the blue for me, for a doctor to recommend one over the other. But her reasoning, I believe, was just because of my age and her concern about future cancers from radiation. So I don't know how much weight I should give that. But with the Decipher score 94, it's just bugging the hell out of me. I've had that score in my mind for 3 months now, and I need to do something.
Yep.
So hopefully I'll be making a decision in the next week or so.
That sounds great. Just hit me up if you need any help making a decision.
All right, thank you.
Thank you. Yep.
So what's on your mind, Henry? I mean, yes, we know you'll need some help. Dr. Dorf recommended your surgery. You're right around 60, aren't you? 61? I can't remember. I don't keep notes, to be
60,
honest, on low intermediate.
64.
64. I mean, 64, there's no reason. It may be Dr. Dorf's preference.
Yeah, she was also against SBRT versus IMRT. So, not.
Yeah, I mean, again, I don't know without sitting down to her and talking with her. We're strongly in favor of SBRT to the point that the JCO has just accepted a letter on my part addressing that very issue, that it's not offered to all patients who are eligible, and it should be. And another study just came out. Watch for our next reminder. Stuart's writing it up right now, which in many ways supports the findings of PACE-B. There are some nuances, there are some differences, but by and large, it really supports that. So, I think that it's all well and good saying, yeah, my patient should go in and get 40 sessions, but she ain't the one who's driving to the sessions. And this is a big problem for us. So, I'm not sure what to say. I will say, what I can say is whether you decide on surgery or you decide on radiation, City of Hope is a good place to get either. Have you, I think we suggested it to you before, have you run the MSKCC nomogram?
Yes.
And what was the likelihood that your prostate cancer would recur within whatever it is? I can't remember, 5 years.
I can tell you for the mortality, it was 2%, and my Decipher score said it's 16%. So it's 8 times greater for mortality.
Yeah, but that's not the issue, your mortality. The issue is recurrence.
Well,
and that's why we ask you to run the nomogram, because the nomogram, whilst not perfect, is going to give you some handle on how likely you are to recur.
Yeah, 5 years 78%, and 10 years 65%.
78% that you will not need, or you will need? 78% that it's going to recur, or 78% that it's not going to recur?
78% progression free.
Okay, so I would say if you're 78% progression free at 5 years, radiation's a pretty good bet for you.
Yeah, and plus you add the Decipher score on top of that. It's
right. So, what specific questions do you have?
Not really. I think it's just up to me making this decision. I guess I'm in the same boat as Jim is, and I have a lot of health issues that I'm dealing with.
Okay.
So I'm a little bit concerned about ADT, but I might, the thing is, if I have the high aggressive cancer or the aggressive cancer, I'm going to probably end up with radiation anyway, ADT. So that's why I'm leaning toward radiation.
Okay. Any comments, moderators, or anybody else in the room? Any comments?
I'm sorry. I'm sorry, Henry, you said you're leaning towards radiation?
Yes.
Okay, in spite of the fact that the doctors who were saying surgery. Okay,
Yeah, I wish
I
she
just,
should. Yeah, if she hadn't said that, I wouldn't even be thinking about that.
okay. So you should not feel like you're sacrificing anything if you feel that you're interested in and believe in radiation. There's no reason to be scared off of it based on any of the stuff necessarily that I've heard. So
Yeah, well, the ADT still is a concern based on my some other health issues I have.
Are you? Do you have heart issues, Henry?
Well, that's still undecided. I'm seeing a cardiologist right now. I'm wearing a heart monitor right now. It's a 14-day heart monitor for basically just checking on an arrhythmia and some other irregular beats.
So I just want to be sure, are you signed up for our ProsCard group?
No.
Are you aware of our ProsCard group?
I am, but I'm still waiting. I'm really in the early part of that in terms of getting some diagnosis.
There will be a meeting next week, I think on the 2nd, which will soon be known as the Heart Meeting once we can get that website up on our once we can get that page up on our website. But there will be a meeting. Let us know if you want your name added to the ProsCard group, and we'll take care of it. I will say this though, 6 months at most, ADT is very, very tolerable. I know because I've done it. I did it for 28 months. And yes, it sounds intimidating. Depending on which ADT they give you, you don't even notice anything for the first 2 months or 3 months.
It would be Orgovix tablets.
Okay, well, with Orgovix, you might notice it a little quicker, but before you turn around, you'll be done with it. Isn't that right, Mr. Sharp?
Totally right. It'll kick in about 2 weeks, and those 6 months will fly right by. Yeah, especially if you're exercising. You've got to lift weights if you're doing ADT. Now,
that's another problem. I'm sorry. I'll let you finish, Dave.
One thing Rick brought up earlier that I'd like to maybe suggest that you consider if you haven't thought of it too much, and also this could apply to Jim Carr too, is brachytherapy. There are some very prominent brachytherapy doctors, very good at what they do, who do not advocate ADT for their brachytherapy patients. Now, not all brachytherapy doctors agree with this, but some of the most prominent ones do, because it's a very potent dose of radiation. If you do the seeds that we were talking about earlier, the whole process, the entire treatment is like 3 hours and you're done. If you do HDR brachy, it's about a half a day and you have to do it twice. I can tell you I've done beam and I've done brachy, and frankly I found the brachy easier because I just slept through the whole thing, whereas with the beam you got to hold your bladder, and which for me with a pre-existing condition was a little tough. And you have to go back again and again and again. Also, the brachy keeps the radiation within the prostate much better than beam does. So if you haven't given a lot of thought and a lot of research to brachy, and you're a little leery about ADT, like one doctor who is preeminent in his field in California who does brachy is Albert Chang at UCLA, considered a top guy. I talked to him. He didn't treat me, but I have a 4+3. He recommended no ADT. And the friend of mine that I mentioned earlier with a 4+4, he met with Albert Chang and was also told no ADT for brachy.
Okay, my Decipher test. There was I can't remember the facts exactly, but it said that I would do much worse with radiation without ADT. I don't have the exact verbatim. I don't even know if that was research only or it was, I think it was probably from the grid report, research only, but there was a trial done on, or some kind of trial done on
that. There have been a lot of trials done on whether to add ADT or not. In most cases, if you add ADT, it's beneficial, but you don't need that much. Have you run the Altera AI test, because that is focused?
Yes, I was at 2.7%, at the very extreme low end.
So,
I would benefit from ADT.
But not by very much if it's at the extreme low end. Is that right?
No, it's the opposite.
Oh,
if it was high.
So, yeah. Okay, because I to be honest, I'm not familiar with the report. So is Altera AI telling you to add or not to add?
To add.
Okay, that's what I would do.
Yeah.
That's what I would do. And you've got to do 6 months. You'll manage. You'll do it with Orcovix. You'll be fine.
Yeah, I'm just worried about starting all over again with a new doctor at UCLA. UCLA is not that convenient. It's a 3-hour round trip for me. And starting all over with a new doctor, I'm not, my PSA spiked 3 years ago now.
Okay, but why do you have to start with a new doctor? Why don't you just use a radiologist at COH?
I don't think they have. I'm not sure they do.
They have.
Yeah.
I mean, what they may not have is MRI LINAC. I don't know. Stuart, do you know if City of Hope has?
No, they do.
Okay, so
they do.
So why do you have to restart? Just go get MRI LINAC at City of Hope.
Oh, okay, I thought we were still talking about brachytherapy. My apologies.
Okay, so if you want to talk about brachytherapy, somebody at COH is doing brachytherapy.
Okay, it wasn't brought up.
I can't tell you who, but I'm sure as an NCCN hospital, there's going to be an experienced urologist doing brachytherapy, HDR at City of Hope. Find out who it is. I mean, I could probably find out just with a quick Google, but just find out who it is, and then there's your man, if you would rather do HDR.
My urologist, I believe last year, he said that I was not a good candidate for it. I can't remember why he said that.
Well, I mean, if you're not a good candidate, then you want to do MRI LINAC. If you are, I can't tell you if you're a good candidate or not without knowing why. I don't know why you wouldn't be. How big is your prostate?
It's not that big.
Okay, so that's okay. Do you have any urinary issues right now?
Not anything severe, just
okay. So you don't have urinary issues. You don't have a big prostate. You need to find out whoever told you why they don't think you're a good candidate.
I do. I didn't. That was quite a while ago, so I'll reinvestigate that. Thank you.
Mir, you're still here?
Mir, I think you're last. Yep.
I am here, and I think this might actually give some of the newcomers who are on the fence some perspective. I had brachytherapy the same day that Joe had his, actually, in Glenwood Springs, Colorado, with Dr. Rossi. I cannot emphasize enough the excellency of the hospital, doctors, nurses, all the staff. Beautiful city, beautiful hospital, beautiful staff. He implanted 93 seeds in my prostate, and I have had very minimal side effects. I have not had, I think except one time, an urge to immediately go to the bathroom. Other than that, no side effects there. The first 2 nights, I got up about 7, 8, 9 times. And then I've been on the Flomax. Since there, I'm taking 2 a night. It seems to help. I get up about 3, maybe 4 times a night. I'm eating.
But you were doing that before.
Yeah,
that was his baseline before.
Right. And eating the regular food, I'm avoiding certain things, alcohol and all that stuff. But the burning is very minimal. It has not impacted the quality of my life. I am back to working out my regular schedule. It was uncomfortable for the first week, especially, we drove back from Colorado to Portland. So sitting, it was uncomfortable, that we sat on the ice and a pillow and all that. But I'm pretty much back to normal. But I want to mention this because I know lots of you questioning surgery versus radiation therapy. When I had my biopsy done, by the way, I was 4+3. They said right away that you should have surgery. Then, we came on AnCan with the help of AnCan, and David introduced Dr. Rossi. We got in communication with Dr. Rossi. We went to MD Anderson, UCLA, UCSF, several doctors in Portland. All of them, except Dr. Rossi, suggested that I should do from 6 months to 2 years of ADT, plus anywhere from a year to almost 3 years of therapy, radiation therapy.
No,
Something like that. Anyway, so we decided to go with Dr. Rossi because I found confidence and I had to make a decision to go with a route. And I'll tell you, I do not regret. I am very thankful to David and AnCan for supporting this, process. And I can't emphasize enough, especially a doctor that they know what they're doing with brachytherapy can do miracles. I don't know what the outcome would be, but I'm very hopeful, and I will let you know in a couple of months. By the way, my brother, who was also had prostate cancer about 15, 17 years ago, he immediately had surgery, and as of today, he is wearing diapers. Just so you know, that's one of the outcome of possible surgery. So that's it for me. Thank you.
Thank you, Amir. So with that, we are done for this evening. Thank you, everybody.
Well, hold on. Anybody got any questions on that, especially the people who have been thinking about seeds? Anything anybody wants to ask Amir?
How long did it take?
He
How
was
long-
in less than an hour.
Okay.
As far as the actual procedure, maybe 40 minutes or something. It's short.
Yeah, the total time we were there from 7:30 a.m. to about 12:30. But yeah, the procedure was about an hour.
Why did you choose seeds instead of HDR?
Main reason was I had triple bypass open heart surgery this last December, and Dr. Rossi felt that this route was the safest route to go, rather than the other route.
Because of only putting him under anesthesia one time instead of twice.
Right. And why did you choose brachy over like MR Lineck or beam?
Sandra, my wife, had done tremendous amount of research, and this was the most promising.
He also had a Prostox test that showed, because we talked to Dr. Keishan at UCLA too. His crosstalks test showed he wouldn't tolerate SBRT very well.
Oh.
So that left him with beam if you go by the crosstalks test.
Yeah.
Yeah.
You know,
Okay.
who wants
Okay.
feel free to please, contact me. I'll be happy to provide any information, any experience that I have had. Yeah, I'm very open to it.
Thank you. Congratulations, Amir.
It
Thank
was
you.
10
Yeah.
months from his biopsy till he finally got treated. So he went 10 months.
Yeah, I've gone a long time too, but y'all really have been through the research and were so thorough and very admirable how you took it on. And yeah, it's great that you've gotten it done and you're so happy with the outcome.
Yeah, absolutely.
Yeah.
I had a question. Amir, how long did you say you were doing ADT for?
I'm not doing ADT at all.
Oh, none at all. Okay, that's what I thought you
No,
said.
no. Yes. At least at this point. Yeah, Dr. Rossi was the only one who said you do not need ADT. And this should take care of it.
Okay, thank you.
Look,
Listen, I gotta say that you guys, the Albert, you make Sandra and Amir look like newbies.
I do.
Yes, you do. So, when are you getting set up? I thought you were already getting set up. When are you getting set up?
Monday.
Monday.
Yeah.
Okay. Do we need to send the AnCan police with you to get you to UCLA?
Yeah, probably. You know me, yeah, you're right. I do make them look like newbies, but no,
You do make it look. Now, are you flying out on Sunday or are you flying out on Monday?
On Sunday.
Good. Okay, I'm glad to hear that because at least if you change your mind, you can still get out there on Monday morning.
Right. Well, we're going Sunday and then we'll stay at that Tiverton, which sounds good at UCLA.
Yes.
Yeah.
Yes. Okay, you better send us pictures of you on the table so we can believe you.
Oh, there we go. Okay. I'll be sure to document.
You be sure to document, indeed be sure to document. Right, Stuart? Anything else you want, Stuart, to make sure he's doing it? Do we need a signed autograph from Kishan?
You'll do fine, Albert. You'll have one day of basically going through everything and then it'll be done. So
Yeah. Well, that's planning, and then I come back the following
21
Tuesday and begin radiation on that Wednesday, and then am there for 2 weeks. So 5 sessions.
planning
All right.
session is actually probably more tedious than the actuals. So
Yeah, it's going to be a long day.
So Greg, you have
go
a
through that.
question? So you get your hand up.
Hey guys, I'm sorry I'm late to the party. Albert, are you going into? I'm sorry I missed all of it, but are you going in for SBR MRI LINAC?
Right, with Dr. Kishan. Yeah.
Okay. Well, you know our good friend Steve. Steve did that with him, as you know, a couple months ago, and he's still alive and kicking, as far as I know. I just heard from him yesterday. So kicking would be the operative word. And I did it up at Stanford with Bionski, and like they say, the setup is probably more tedious than the 5 sessions themselves. They were telling me that usually you'd be in there for 45 minutes or something, and I can't remember ever being in there more than 30 minutes. And maybe that's just because I held still, but I found it to be much. It wasn't a very long time in the tube, but I did just for fun, and just for the yucks, I did take a lorazepam before going in. And I found after a couple of times that I really didn't need it, but I said, what the heck, I got the prescription, so I might as well use them. So anyway, I always came out happier than when I went in. But it's the one thing I would remember and recall is they want you to drink a lot of water. And I don't know if Kishan, are you using Spacer or Spacer?
Yeah, definitely.
Yeah.
I'm not sure which one, but.
Okay. Yeah. See, I didn't have that. Bjornsky doesn't do that for whatever reasons. And I was just advised to drink lots of water, which I did. And that's supposedly to get actually get things out of the way. So
yeah.
But it's been 6 months plus right now, and my PSA dropped the first 3 months. It dropped from 7.7. I guess the highest it ever got was about 7.1, and it dropped to 2.7 after 3 months. And so I'm due to get another PSA in the next. I'm going to try to get one in a few weeks just to see where I'm at now. But this is not to brag, but I just had sex, so that's why I was a little bit late coming to the show. So anyway, so that's still working. So just want to let you know it's not the way it used to be, but it's still functional. So so anyway, it's been an adjustment, and it was scary going in, and I look back on it 6 months now and go, wow, I was scared, and it's behind me now. So I wish you well in LA, and I understand that's a great facility, and the place you're staying is great. And so I try to have a good time while you're there, and have a little bit of vacation. I know LA isn't the LA it used to be, but it's but heck, you're in the middle of Hollywood there, I guess. So yeah, I mean, it'll be make a vacation of it as well as if you can.
Right, get to the ocean. Did you do ADT? Are you on ADT?
No, I'm not. Good friend
fine.
Steve is. Steve is, as you probably know, but no, I'm not.
Yeah. You didn't have large cribiform, or what were you? 4+3, 3+4?
No, I was 3+4. Not a
Yeah.
lot, not a whole lot of 3+4, but I had several spots of 3+4, but no cribiform.
Nice.
And so I feel grateful that I didn't have to go that route. Are you having to do ADT?
I'm on Orgovix now, and it's no problem for me so far. I work out every day, and I haven't really felt anything.
Excellent.
Yeah.
Well, good. Well, listen, you've been in good hands with these people here, and you'll be in good hands there. And there's a Bruce Springsteen song. I can't remember all the words, but it's something like there's a line that says, someday we'll look back on this and it will all seem funny. And though I am tone deaf and I can't sing, I do like that line. I think it's a good one for us. And so you'll look back on this and in a few weeks and it'll all seem funny. So carry on.
Burns.
Have a good trip.
What do you mean?
Yes.
What do you mean I'm tone deaf, I can't sing? You can't have everything, man. You paint, you're a fantastic athlete, right? You're having sex in your mid-late 60s. No, some things you can't have. So that's what I would say.
There you go. I always like your perspective.
Okay. All right, close it out. Now you can close it out. Now that we've heard from Greg Burns, you can close it out, Boykin.
Okay. Hey, good night, everybody. Thanks for coming.
Good night, everyone.
Thanks, guys. Bye-bye.
Bye.